Okay, thank you so much for having me. I'm going to talk about a report that we did last year and then a report that we're working on right now. Let me see. How does it work? The right button. Okay, sorry. This is a report, Telehealth, Mapping the Evidence for Patient Outcomes for Systematic Reviews. That was, so what happened was the Senators Thune and Nelson requested that AHRQ review the evidence on telehealth, which is a huge request. There are thousands of studies on telehealth and hundreds of systematic reviews. So we started with a very, very broad overview. The report was done by the Oregon Health Sciences University Evidence-Based Practice Center. Particularly, I want to acknowledge Annette Totten and the rest of her team, but unfortunately she couldn't come today, so you have me. So what were the questions that we looked at? We looked at what is the current research on the effectiveness of telehealth, and what are the gaps in existing research? And we did this by having a very broad overview of systematic reviews. So we started with the hundreds of systematic reviews with the idea that we wanted to make sense on a very high level of the enormous amount of literature. And in 10 minutes, I don't have time to go through all the findings, so I really encourage everyone to read the report if you haven't already. But I tried to pick out some of the highlights of what we found. So we did this consumer reports kind of diagram of the results. So down here you have like the different conditions, so mixed chronic conditions, cardiovascular disease, diabetes, and across the top, the different kinds of telehealth: communication and counseling, remote patient monitoring, multiple function psychotherapy, et cetera. And you can see that a lot of the systematic reviews are clustering in certain places. So for consultation, for example, there were hardly any systematic reviews. So I'm going to get back to that. But for things like cardiovascular disease and remote patient monitoring, lots of systematic reviews, lots of green bubbles which show that there is a benefit. So we don't need to look at that anymore. Okay, there are systematic reviews that says there's a benefit for cardiovascular disease and remote patient monitoring. And when we do technology assessment, there's questions of can it work and will it work? So we've demonstrated that remote patient monitoring for cardiovascular disease can work. There can be a benefit, but will it work in clinical practice? We need to move on to that question. In this slide, I'm just showing some of the outcomes. So there are outcomes like mortality, fewer disease exacerbations, higher quality of life. On the cost side, there's fewer hospitalizations, and other kinds of cost outcomes. And in the conversation that everyone was having in this room, the idea of standardization, I heartily agree with that. It's very difficult when every study is measuring different outcomes. This is looking at the cost and utilization. Again, this kind of consumer reports kind of diagram. And again, you see like the most evidence, the most systematic reviews with the most green: cardiovascular disease for remote patient monitoring. And I just want to point out that not all the studies are consistent with each other. So, for example, on emergency department visits, there's different systematic reviews found different results. And that's because the details matter. So, and I think that people were having that conversation in this room this morning. Before I go to the key findings, I should have put these in the other way around. But there's all these different variables that are going on. So the way the authors of the report actually described it is like looking through a soda straw. So each individual study is just a snapshot of a small part of this whole ecosystem. So we really, really need, for some things like remote patient monitoring and cardiovascular disease, we need to move beyond those RCTs in single settings with single type of population and really look at a broader implementation. So our overall key findings is that the research literature is vast and varied. There's hundreds of systematic reviews and thousands of studies. There's sufficient evidence to support the effectiveness of telehealth in some settings for some types of patients, particularly remote patient monitoring for patients with chronic conditions, communication and counseling for patients with chronic conditions, and psychotherapy as a part of behavioral health. And for these telehealth applications, the research focus needs to shift to how to promote broader implementation and address issues. And we actually talked to staffers in Senator Thune and Nelson's office going over the results of these, and that is what we told them, that for these applications of telehealth, we don't need any more of those small RCTs. We need to move on to broader implementation. But additional systematic reviews may be helpful for some topics, including consultation, so I'm going to talk about that in a minute. And other uses, such as triage for urgent care, there's limited primary evidence. So again, if you look at the whole report, we have a lot of charts of where the evidence is and where the evidence isn't. And if you are going to do randomized controlled trials, I would suggest trying to do one in those places where there are gaps. And of course, future research should also assess the use and impact of telehealth in new healthcare organizational and payment models, and I'll talk about that. So we're doing a follow-on report right now on telehealth for consultation. So, and here's how we define consultation: the use of telehealth designed to facilitate collaboration among providers, often involving a specialist or between clinical team members across time and or distance on the assessment, diagnosis, and or clinical management of a specific patient or group of patients. And again, if you look at the evidence map, we did try to define all the different types of telemedicine. And again, I really agree for the needs of having standard ways of describing all these things and characterizing them. So these are our questions. So are telehealth consultations effective in improving clinical and economic outcomes? Are they effective in improving intermediate outcomes? Have telehealth consultations resulted in harms or negative unintended consequences? What are the characteristics of the telehealth consultations? And do clinical, economic, intermediate, or negative outcomes vary across telehealth consultation characteristics? And then the other thing that we're doing that I'm really excited about, because we do this sometimes, but not often enough, and that's using decision modeling. So we are actually working with our colleagues at HRSA and Medicare, and we want to look at different types of payment models. So can we take the evidence and different types of payment models, either payment models that already exist or payment models that are being considered, and model out what are the predicted effects. So I think that that's something that's really exciting, and in the discussion we can talk about that more. And I just wanted to point out that we have a request for information in the Federal Register right now. So if you have any studies on consultation, especially unpublished studies that we're not likely to find in the literature, we would love to hear about it. Don't send us anything that cannot be made public. But if you're willing to have it be made public and put into our report, we'd love to hear about it. There's kind of a long URL at the bottom, but if you also search Google on ARC, Federal Register Telehealth, you'll find it. So I look forward to talking to you all in the discussion.